Welcome to the Post Medics. In today's video, we'll talk about pneumonia. So what are we going to cover in this video on pneumonia? So we will talk about the definition of pneumonia, types, the causes, the pathophysiology, clinical manifestations, diagnosis, and then the treatment. So what's pneumonia? Pneumonia is an inflammation of the lung parenchyma caused by microbes. There are other factors which may also lead to inflammation of the lung parenchyma, not always by microbes. As you breathe in air, these microbes may be present and may be successful in invading our respiratory tract, leading to pneumonia. These microbes may be broadly divided into viruses and bacteria. Common viruses that may cause pneumonia is influenza, which is commonly known as the flu. For bacterial pneumonia causing microbes, we have Streptococcus pneumonia, Haemophilus influenza, Staphylococcus aureus, Mycoplasma pneumonia, Chlamydophila pneumonia, and we've also got Legionella pneumonia. These causes atypical or working pneumonia. Now, fungal causes are rare in individuals with normal immune system. Fungal causing pneumonia microbes include coccidioidomycosis, which is known in California and Southwest. Then we have blastomycosis in the east, histoplasmosis in Ohio, and cryptococcus, which can be found in anywhere. We also have pneumocystis jirovecii. This is common in immunocompromised patients. Now, in patients with HIV, CD4 count may be less than 200. Depending on where pneumonia may occur, this may be divided into lobar pneumonia. So what's lobar pneumonia? In lobar pneumonia, there is a consolidation of the whole lobe of the lung. They may also have bronchopneumonia. In this type, infection spreads throughout the lungs, involving the bronchioles and the alveoli. We also have interstitial pneumonia. And in this type, infection is outside the alveoli, within the interstitium. Now, the causes of pneumonia may also have the non-infectious causes, and these include aspiration of food or gastric contents. Now, aspiration refers to the inhalation of gastric contents to the lower airways. So, for instance, if you are taking a biscuit and instead of swallowing into the esophagus, you mistakenly breathe in and it gets into the windpipe. So, in this case, we say you've aspirated. Your body reflexes such as gagging and coughing may take away the aspirated food from the lower airways. But in certain cases, these reflexes may be compromised due to certain drugs, alcohol, brain issues, or swallowing issues. The certain content would then cause direct chemical injury to the bronchial and alveolar epithelium, leading to inflammation, edema, and necrosis of the lung tissue. The food will therefore be stuck in your lower airways, and this is what we call aspiration pneumonia. Another non-infectious cause may be hypersensitivity reactions, and this is a type that involves type 3 and type 4 hypersensitivity reactions. The immune system responds to inhaled organic antigens with immune complex formation and T-cell mediated. This leads to intestinal inflammation and infiltration by lymphocytes and macrophages. Another non-infectious cause could also be drug or radiation-induced pneumonitis. So drugs like methotrexate can cause direct lung toxicity. It can provoke oxidative stress, immune-mediated lung injury, leading to inflammation and therefore pneumonia. The inflammation brings fluid into the lung tissue or the respiratory system. So you've got a trachea, and this goes down to divide into the left and the right bronchi, which also divide further into the bronchioles and finally in the alveoli. Now, the alveoli are tiny air sacs or gaseous exchange case. So during the process of inhalation, air travels down your trachea through the bronchi into the bronchioles and finally within the alveoli. In the alveoli, this is where gaseous exchange occurs. So oxygen leaves the alveoli and enters the bloodstream, while carbonic oxide leaves the bloodstream to the alveoli. You've got mechanical techniques such as coughing, where the mucociliary is to move out larger bacteria and macrophages that are ready to destroy and then the lungs there. But in certain cases, despite these mechanisms, some microbes may be successful in invading the respiratory pathway all the way from the trachea to the alveoli. These microbes, which are successful in colonizing, will now multiply across the lung tissue, causing inflammatory response, and finally, you got pneumonia. The tissues now become full with white blood cells together with proteins, fluid, and even red blood cells if nearby capillary gets damaged in the process. Certain fungi may affect or impair the mucociliary defense. In patients with COPD, hemophilia influenza, and Moraxella catarrhalis may affect the mucociliary defense. Elderly individuals and those who smoke may also be prone to Legionella, which may reduce or impair the mucociliary defense. Certain conditions such as cystic fibrosis, bronchiectasis, malignancies, primary cellular dyskinesia may increase mucous thickness, which may also reduce the defense system of the mucociliary cells. Pneumonia may also be grouped into community-acquired pneumonia and hospital-acquired pneumonia, which is also known as nosocomial pneumonia. Now, in hospital-acquired pneumonia, also known as nosocomial, this is acquired in the health facility or the hospital. These may be found in immunocompromised patients who are already hospitalized for other conditions. Usually, organisms causing this type of pneumonia are gram-negative bacilli, Staph aureus, Pseudomonas. And there is a subset of hospital-acquired pneumonia called ventilator-associated pneumonia. These develop when ill individuals are connected to a ventilator. Individuals on ventilators can't cough, and microbes which form a biofilm on the tube may move into the lungs and cause pneumonia. Then you have community-acquired pneumonia, which casually arise from overcrowding the community, as the name suggests. So this type of pneumonia is developed outside a health facility. Organisms involved in this usually are Strep pneumonia, Mycoplasma pneumonia, Haemophilus influenza, Staph aureus. We also have another category that is healthcare-associated pneumonia. This encompasses cases caused by multi-drug resistant pathogens, typically associated with hospital-acquired pneumonia. This is associated with increased use of broad-spectrum antibiotics, particularly those employed for treatment of methicillin-resistant Staphylococcus aureus and anti-pseudomonas beta-lactams. Now let's talk about the stages of pneumonia. There are actually 4 main stages of pneumonia. That's in the case of lobar pneumonia. The first stage is congestion. This is the early response to infection. The alveoli become filled with exudates. That's a protein-rich fluid as capillaries become congested and leaky. Bacteria multiply rapidly in the alveolar spaces. The lungs appear heavy, dark red, and bulgy. Now let's move to our second stage, that's red hepatization, which is also known as the consolidation stage. The lungs become solid and liver-like. That's why we give the term red hepatization, hepa referring to the liver. There is massive neutrophil infiltration as the immune system tries to fight the infections. The third stage is the gray hepatization stage, which is the early resolution stage. So RBCs within the alveoli break down, leaving behind fibrin and leukocytes. The color ranges from red to gray due to disintegration of the RBCs and persistent fibrin. Macrophages begin to dominate, initiating cleanup. Then we have our last stage to be the resolution. So the fibrinous exudate is enzymatically digested by macrophages. The debris is resolved, coughed up or drained via the lymphatics. Normal lung architecture is gradually restored. Let's talk about the risk factors for pneumonia. So these include malnutrition, low birth weight, measles, environmental tobacco or smoke, and overcrowding. Now we move to the clinical manifestations. So what are the signs and the symptoms of pneumonia? Pneumonia is frequently preceded by several days of an upper respiratory tract infection, typically rhinitis and cough. Now in viral pneumonia, fever is present but temperatures are generally lower. It may also be tachypnea. There is severe infection accompanied by cyanosis and lethargy. The auscultation of the chest may reveal crackles and rhonchi. There is increased risk of breathing that's accompanied by intercostal, subcostal, and suprasternal retractions. Distal flaring and use of accessory muscles are common. High fever may be present, cough, chest pain, diminished breath sounds, and dullness on percussion. Now, you have to know that pneumonia is a state of consolidation. So let's talk about signs of consolidation. That's a state of the lung being the state of the lung with alveoli filled with fluid. So there is reduced chest expansion. There will be increased tactile vocal fermitus. This is when you feel more vibrations in your palm from a person's chest when you ask to repeat certain phrases after you. Then you may have dull percussion notes. There may be presence of bronchial sounds or crepitations. Then there will be increased vocal resonance. Then low oxygen saturation. You may have a sputum that is rusty or blunt stain. And in children, there may be presence of grunting and then chest wall indrawing. Now let's look at some investigations that may be done to diagnose pneumonia. So one of the investigations is doing chest X-ray. And in chest X-ray will be your findings. So there will be consolidation, that's air opacification. There will be increased lung markings, especially in early or interstitial types. Then there will be loss of lung volume occasionally. So lobar pneumonia, there's homogeneous opacification. Air bronchograms are often present. Serial sign is positive as loss of the heart border. Fluid is localized to a single or set of lobes. In bronchopneumonia, what are your findings? So there is no air bronchograms. It's patchy, ill-defined opacities which are centered around the bronchi. What are our findings in interstitial pneumonia? So it may be diffuse, as opacification may be diffuse reticular infiltrates. It is more prominent in the perihilar and lower lung zones. Another investigation we may do is ultrasonography, and this is highly sensitive and specific in diagnosing pneumonia by determining lung consolidations or effusions. We also do our full blood count. The peripheral white blood cells count can be useful in differentiating viral from bacterial pneumonia. In viral pneumonia, the WBC count can be normal or elevated, but usually not higher than 20,000 per millimeter cube with a lymphocyte predominance. Bacterial pneumonia is often associated with an elevated WBC count in the range of 15,000 to 40,000 per millimeter cube, the predominance of granulocytes or neutrophils. We may also talk about recurrent pneumonia. So what's recurrent pneumonia? So this is defined as 2 or more episodes in a single year or 3 more episodes ever, with radiographic clearing between occurrences. Underlying disorder should always be considered if a child experiences recurrent pneumonia. We'll talk about complications of pneumonia. So pneumonia can lead to lung abscess. It can also lead to bronchopleural fistula, pericarditis, pleural effusion, or empyema thoracis, pneumothorax, endocarditis, meningitis, and sepsis. So what's our mode of treatment? So we want to give antibiotics depending on the type of pneumonia, the microbe that may be involved. We also do other supportive care such as giving oxygen for low oxygen saturation, giving of pain medications, cough suppressants, and we also hydrate and then offer nutritional support. As well, we have to treat all other complications that may be present. If you found this video, kindly subscribe to our channel and comment below the topic we should cover. Thank you.